Welcome to QD Clinic. Hi, I'm Jack Cush with Room Now. QD Clinic is brought to you by, this month, PsA All the Way, our focus on a big problem in rheumatology. Today's case is what to do with the DIPs. That's a reference to the police. 57-year-old male presents to you with DIP arthritis going on for, he says, the last, 6, 5, 8 years. He doesn't really know. He just says that recently the pain, stiffness, and swelling in his fingers is getting worse. You look down, it's really the DIPs. He denies any rash, bowel, or urologic problems, no eye problems. He's been taking over-the-counter non-steroidals. You do x-rays, you get labs. Labs are seronegative, and the uric acid is normal, and the x-rays show evidence of erosive disease, and you diagnose psoriatic arthritis on the basis really of the fusiform swelling of those DIPs, the sort of somewhat squishy synovitis, the redness, the presence of onycholysis, and then on a deeper, more intensive search, you find that there is other cutaneous evidence of psoriasis in this individual. So what's the differential diagnosis of DIP arthritis? You can get it in RA, and in fact, there's a study from a few years ago saying that minor subset of RA patients that does have DIP involvement are actually patients who have really worse disease. So in RA, it can be a bad news, and certainly RA is maybe a little bit more prevalent than is just psoriatic arthritis. DIP can also be from multicentric reticulonodular histiocytosis, MRH, very, very rare. But DIP involvement is really almost always seen in MRH patients. Obviously, erosive OA, rarely patients with SAPHO, but it's OA, erosive OA, and PsA are often the differential diagnosis. While DIP involvement can be seen in 40 to 50% of patients, exclusive DIP involvement can be seen anywhere from 15 to 25% of patients. And as you know, one of the old teaching things is that nail involvement in PsA portends a greater risk of DIP involvement with PsA, and DIP involvement in PsA is one of the 5 subgroups in the Mole and Wright classification system. Oligoarthritis, which is the dominant group, polyarthritis, the next dominant group, DIP arthritis, arthritis mutilans, and what we now call axial psoriatic arthritis, which had a great session by Phil Meese at Room Now Live. You might want to look at that in the months to come on Room Now. But so, again, DIP arthritis is one of the 5 categories. There's some argument in the literature in the last 20 years about whether that deserves to be its own separate category. More recent studies have shown that it's the onycholysis and the hyperkeratosis that actually is best predictive of DIP involvement. Are they treated any differently? Not really. Again, you would use the same drugs. He's already failed non-steroidals. You could go on to methotrexate and then escalate from there. Sulfasalazine, of course, which you would not use in axial PsA, has been shown to have some value in these patients. Plaquenil, obviously not. Steroids you should avoid. And then you can go into some of the other approved therapies, which haven't been specifically studied in as subsets. And now we're seeing with a lot of the IL-17, IL-23, IL-12-23, and JAK inhibitors, as you see more and more studies, and we're seeing lots of studies in PsA, you'll start to see more subset studies. I think we'll be discussing that in the next month. That's it for QD Clinic. Tune into more about PsA all the way throughout April 2022.